We're going to talk about epidemiology of mood disorders. So here there were three major national surveys on the prevalence of mood disorders. If you look at the last one, that's the survey in the early 2000s, you see here that the prevalence of major depressive disorder as well as dysthymic disorder approaches 20%. In other words, 1/5 of our population at some point will experience depressive symptoms. This is opposed to the 3.9% prevalence of bipolar 1 plus bipolar 2 disorders. It's very interesting because when you think that these are genetic illnesses, it's as if natural selection chose the depressive position greater than the hypomanic or manic orientation. It's as if natural selection made us into a depressive species. Now, the annual prevalence is, so at any year you're going to get 5 to 10% or 9% of the population is going to meet criteria for depression. The lifetime risk of a major depressive episode is 17%. With women far more women, it's almost a 2-to-1 ratio of women to men in terms of experiencing a major depressive episode during their lifetime. Recurrence is the rule rather than exception. I tell patients, look, after one episode, I usually say you've got 1/3 chance, 30% chance of having another episode. After 2 episodes, you've got over a 66% chance. And after 3 episodes, you're virtually guaranteed to have further episodes during your lifetime. But these are real numbers, 50, 70, and 90. And 1/3 of people are going to have episodes that last more than 2 years. And what do we call that? Persistent depressive disorder. So we got nearly 1 in 5 Americans, if you include major depressive disorder and persistent depressive disorder. During a lifetime, 20% of Americans will have had a major depressive episode. Females about twice as often as males. First episode of for major depressive disorder is age 20 to 40, but most in the early 20s. There is a increased risk in people who are unemployed, single, or divorced, who have low education or are poor. Interestingly, the risk may be lower in Latinos, Blacks, Asians, and first-generation immigrants. And the risk is lower in individuals over the age of 60. Now here's a study out of the University of Pennsylvania looking at the rates of depression among medical students. High impact article. It was published in the New England Journal of Medicine. It's also been replicated in other medical schools in the country. So if you look all the way to the left here, you see among women there is a point prevalence, meaning an incidence, at the same time as the survey was taken, that there were nearly 20% of female medical students met criteria for depression. Slightly smaller percentage of the male students were depressed at the time of the survey. If you look at race or ethnic group, it's interesting the Latino population had a much higher incidence of depression at that point. And if you look at the 1st through 4th year of medical school, you see that the M1 and M2 years were the highest. In other words, in your class right now, 20% of you have significant depressive symptoms. Looking all the way over to the bar graphs in point B, you actually look at, of the students who were depressed, how many received treatment. Overall, only about 25% of the students who were depressed received treatment. Now, if you look at students with severe depression, you see only 30% received treatment. Now, if you look at students with suicidal ideation, again, only 30% of students with suicidal ideation sought treatment. These are really abysmal numbers, as I'm sure you'll agree. And again, this has been replicated in other medical schools successfully. All right, in the medical setting, you also have an increased point prevalence with 10% of people who are currently hospitalized meeting criteria for a major depressive disorder. You've got, in primary care, twice the prevalence of the general population, and this is for annual prevalence. Major depression is 10 to 15%, dysthymia is 6 to 8%. For chronic medical illness, the incidence is 4 times the general population. So 20% of patients hospitalized today for a heart attack will actually meet the criteria of having a major depressive episode. So depression and medical illness, it increases morbidity and mortality. So many studies showing individuals had a stroke or even an MI, their chances of being alive 1, 2, 3, 4, 5 years after the event is actually lower. So the depression complicates the morbidity and mortality associated with the illness. And this has been well demonstrated on all these conditions that I'm showing here: stroke, diabetes. By the way, depressed diabetics have more poorly controlled diabetes, coronary artery disease, cancer, congestive heart failure, and HIV. A landmark study in 2002, which has been replicated in dozens of studies. Here you've got 876 patients hospitalized with a myocardial infarction, and they're all screened using a tool called the Beck Depression Inventory, or the BDI. A BDI less than 5 means no depressive symptoms, 5 to 9 mild, 10 to 18 moderate, and greater than 19 is severe. And you see a dose-related response in terms of 5-year mortality. Here are the people that are not depressed. Well, they got a good chance of being alive 5 years later. And here you look at the people with severe depression, and you notice there's a 25% 5-year mortality rate. So what this tells you is, and this is, by the way, even after you control for known cardiovascular risk factors. So to statistically control for high cholesterol, smoking status, age, blood pressure, you name it, even after controlling, depression is an independent risk factor for post-MI mortality. It's pretty shocking, but it's true. Now, I showed you this earlier, and I'm showing you this again because I want to point out patients are not going to come out and tell the cardiologist while they're in the hospital, hey, gee, I've got depression, and I've heard that can complicate my course. So patients need to be screened. They're not going to tell you because of all these reasons that we reviewed in the introduction to psychopathology. So very important that your patients post-MI, patients with other medical illnesses are screened. Now, here is a receipt, sales receipt from Party City. The individual bought 2 items, and this was in 2009. One of them was a helium tank, and the other was a greeting card. The greeting card was sent to his ex-girlfriend. The helium tank was used to kill himself. He was found later that day with a mask connected to the helium tank. He was found dead by his roommate. This is one of my patients. So the latest numbers that I have are from 2015. There may be some new ones for 2016 out. I haven't yet checked. But it's not going to be substantially different. So nearly 43,000 people killed themselves in 2015, making it the 10th leading cause of death in the US. Striking, 3/4 of these patients who have killed themselves have seen a healthcare professional in the prior month. Now, maybe that healthcare professional knew the patient was depressed, but did not ask about suicidality. But maybe the healthcare professional didn't even ask while the suicidality was brewing. And of people who killed themselves, depression is the most common diagnosis. According to U.S. mortality statistics, which of the following claims more lives each year? Breast cancer, suicide, motor vehicle accidents, prostate cancer, or AIDS? Well, here you go, people. Suicide kills more people than breast cancer or motor vehicle accidents. Now, I'm going to claim that suicide has far more than 44,000 deaths per year. And why? Because the fifth leading cause of death is accidental deaths. And here, if you look at the 2014 data, the total accidental deaths is 3 times the number of deaths associated with suicide. Okay, but what comprises those accidental deaths? Falls, motor vehicle accidents, poisoning, drowning, or smoke or fire. Now, I'm going to argue with you that probably somewhere between a quarter and a third of these motor vehicle accidents and poisoning and drowning and carbon monoxide inhalation and falls from the 3rd floor of an apartment building are actually suicides. Well, then why aren't they classified as suicide? Because the tendency for the family and even the practitioner is not to label these suicides, but to label them as such. You'd much rather call it, well, the person died in a car accident than, well, they voluntarily drove themselves off the road and the car with them included fell off a cliff. So if 20% of accidental deaths are intentional, the number of suicides per year goes to 70,000, making it the 8th leading cause of death, just below diabetes. And I really believe this. Suicide rate has climbed up every year. Why? There's a whole bunch of different potential reasons. One, of course, is the economic crash of 2008 that took a lot of people time to recover from, destroyed lives. But even now that we're in economic recovery, the suicide rate is going up. Now, this is 12.5 suicides per 100,000 population. But in addition to suicide, where it's completed successful suicide, there's 1 million people a year making suicide attempts. Okay, so if you're an ER doctor, you're going to see a lot of this. Patients hospitalized for depression, they've got a 10% lifetime risk of killing themselves. I have a little mnemonic named MAPS for features that significantly increase the risk of suicide. M is for mania or hypomania, so bipolars have the highest risk among all psychiatric disorders of suicide. Person who's actively using alcohol and drugs, higher risk of killing themselves, often by overdose. Person who has psychotic symptoms, no matter how subtle, has a higher risk of killing themselves. And anyone who's made a prior suicide attempt is at risk for making a more successful suicide attempt in the future. You can never, ever, ever let a patient leave your office if they screen positive for depression. You must ask about MAPS and document it, okay? Otherwise, you're inviting a lawsuit that they look at your records, the person's depressed, and there's no documentation that you ask them about suicidality, mania, etc. What are the demographics of suicide? We all think about adolescents as most likely to kill themselves, but actually it's elderly white male have the highest risk. Those who live alone, financial, legal problems, are unemployed. Possession of firearms, got to ask patients too, do they have firearms at home? Easy to forget, but that's an important question to ask, and if they say yes, make sure that they secure their firearms by giving it to somebody else to watch. If the person, the victim, feels hopeless, neurologic illness such as multiple sclerosis, stroke, brain tumor, the risk of a patient with concomitant neurologic illness and depression increases the risk of suicide. Very interesting. And a family history of suicide always freaks me out because that's another big risk factor that this is suicide itself is genetic. But when your parent has killed himself or herself, the message to this child is, well, that's an acceptable behavior for when you're really down. He or she did it to me, so I can do it to whoever loves me as well. And this concludes our discussion of the epidemiology of mood disorders and suicide.